Welcome. Thank you very much for joining us, both to those who are able to attend today and those of you who are going to be joining the webinar on your own time as it's made available. Welcome to the PTACC Strategy Area Seminar. This is the second in a series of 7 of strategy areas in the field, and today's presentation will be about treatment, housing, and recovery, specifically in those areas. I'm Andrew Sidoli. I'm a licensed clinical social worker, and it's a pleasure to be part of this team. I wanted to open it up and introduce the panelists for today, and I am going to start with Dr. Bob Lin.
Good day, everyone. I'm Bob. I'm Bob Lin, and I'm a psychologist and a sociologist. So I do research and clinical work, and I've been doing that for about 50 years and throughout the world, literally. So, and I'm happy to be here today. It's quite a pleasure. And my major focus these days is on what I'm calling the crisis of credibility in addiction treatment, which I think is been around for a long time, but during these challenging times is right in our face and something we need to deal with aggressively. Thank you.
Hi.
Andrew, you're on mute.
Thank you, Dr. Bob. Apologies. Steve Valley, would you be so kind as to join us and introduce yourself? Steve, you're mute.
It's a good thing I was told to unmute myself, huh? Hi, everybody. Thank you for joining us. Dr. Steve Valley. I'm a president and CEO of AdCare Criminal Justice Services, and we provide a variety of drug and alcohol, trauma-based, gender-specific programs for folks who are involved in the justice system, both behind the walls, in prisons, jails, and in community correction centers. And I've been doing that for about 25 years, and then the first 15 years of my career was spent in the private treatment world, and I constantly go back and forth between the private treatment world and the public sector world, as my parent company, AdCare Hospital, is a part of the addiction treatment American Addiction Centers network of hospitals. So I kind of interface in both the criminal justice world as well as the private treatment world.
Thank you, Steve. Dr. Safir.
Good morning, everyone, and thank you for joining us. I'm Rashad Safir, and I'm the president and CEO of the Bobby E. Wright Comprehensive Behavioral Health Center. We're located on the west side of Chicago. Bobby Wright has been around since 1973. We are a predominantly African-American facility that serves a predominantly African-American population on the west side of Chicago. I am also the co-founder and director of the West Side Community Triage and Wellness Center, which is a freestanding deflection pre-arrest diversion facility on the west side. We work with 5 districts of the Chicago Police Department. We're also doing some fitness diversion with 3 branches of the criminal court on the west side. Our facility also has a wellness component where we address some of the social determinants of health. We know that many people end up either in emergency departments or inpatient facilities or have contact with law enforcement because of issues related to housing insecurity, food insecurity. So we're trying to really address some of the underlying conditions that lead to these inappropriate and sometimes traumatizing events for people on the West Side. So thank you, and I'm happy to be a part of this panel.
Thank you very much. Appreciate that. Melissa O'Mara, would you?
Thank you. Good afternoon, everyone. My name is Melissa O'Mara. I am an assistant prosecutor with the Burlington County Prosecutor's Office, which is located in southern New Jersey. I'm also a person in long-term recovery from drugs and alcohol since August 30th of 2011. I, in my role as an assistant prosecutor, oversee multiple deflection and diversion programs. I also participate in a wide variety of recovery support services and building community where I'm located here in New Jersey. I'm very pleased to be on the call today to discuss police treatment and the community during COVID. And I look forward to discussing multiple topics on the webinar today.
Thank you very much. And last but not least, Leslie Belanek.
Hi, everyone. Thank you for joining us today. I'm Leslie Balanek, as said, and I've been in the substance use field since the very early 80s. And I'm just going to, so my experience is varied, working with Department of Corrections, national behavioral health companies as a senior executive. But the roots of who I am and what I continue to be is, I learned the field, primarily spent an enormous amount of my clinical days doing assessments. But I was grounded in the community, and the title of this workshop is Taking It to the Streets. And so that's been my foundation, is the streets. Even as a professional, going out there where the clients are, where the problems are, and integrating and engaging at that level, and helping to teach people how to do that. I started doing assessments in lockup at the Cook County Jail, where you're standing up and they're in the, back in the day, the drunk tank or the bullpen. I mean, that's how far. And we opened up the courts at that time for alternatives to incarceration. And I think many of the folks on this panel come from that same experience. And it's interesting because it's kind of like full circle. Now we're back to persons with lived experiences, doing outreach, going out there in the communities and working in partnership with law enforcement and treatment providers. And so the lessons learned from long ago and the new opportunities is what intrigues me. And just to move along, most of my career has been spent with the justice system, whether that's community-based or institutional-based treatment. That's been my varied experience. Years ago, they said, you want to do the same thing for 40 years, or you want to do different things every year and then combine it together. So I was lucky enough to have some good mentors that helped me define how to channel my passion into implementing and making something happen. So it's just a true pleasure to be on this call, and I'm looking forward to the conversation with my colleagues and your questions. I'm also, I am the Vice President of PTACC Executive Council, and have been involved since its beginnings several years ago, and I'm really proud of how far we've come as a collaborative to be the national voice in deflection and pre-arrest diversion. So thank you.
Thank you, Leslie. What an assortment, a variety of experience, and what a distinguished panel to have on this webinar. Thank you all. I wanted to just be able to refer to the slides and point to some more information about PTACC. I'm Jack Charlier, who is the executive director, unfortunately couldn't be with us today, but wanted to make sure that you have his contact. Here is his phone number and his email and the website. So what is the PTACC conversation really all about? Well, the idea is to really present live discussions with a national panel of panelists who are in the field, and to have this be a really interactive experience. The idea is not to sort of present or lecture. The idea is to be engaging with you. There are many experiences in the field, many communities that are already involved in both deflection and pre-arrest diversion. And we want to be a resource. We want to be open to all in the field of deflection, whether you're already sort of there, and we want to hear about your experiences because your experiences are valuable to others in other communities. It's free, and it's hosted by the Frontline Responders Network, who is a valued PTACC partner. Please take a look at our website. The mission, purpose, and cornerstone is really, the idea is to enhance the quality and the quantity of community behavioral health and social service options through engagement in deflection and pre-arrest diversion. But the primary sort of purpose and really the operating paradigm is to reframe relationships, primarily between the police, the community, the treatment and recovery field, and housing and harm reduction. So the purpose is to provide a sort of thought leadership, a vision leadership, advocacy, and education to facilitate both deflection and pre-arrest diversion across the United States, to some terms, in sort of providing best practices. PTACC is open source. It's open to any and all. So there is no sort of cookie cutter or no sort of standard approach. Understanding that every single jurisdiction, every single community must be able to determine its own approach to solve its problem. So it's really through that community engagement and sort of collaboration. PTACC has been partnering with a number of national partners, and here is some that you will probably recognize. And if you're not already a partner, I'm sure you will find connections through the national partners. I'm sure you will know sort of colleagues and others who are involved. And here are some more of the national partners who are involved in the PTACC community. So as you can see, it is a very wide and broad coalition of partners, and here is our National Deflection Resource Center. I do want to remind you, all of you in the audience, that we are going to have Q&As. We have a moderator so that we can sort of bring up questions. We will have a live Q&A at the end, so it'll be through a sort of raised hand, and we'll be able to sort of bring you in directly to ask a live question and interact with the panel. But just wanted to just finalize on the resources that PTACC offers to the field. So please take a look at the PTACC ticker. It's a free weekly newsletter, the entire field. It will cover a variety of subjects, some of which will be covered today, and a lot more. Please sign up. There are the visual 5 pathways to treatment. So it's a really sort of interesting schema to allow you to sort of visualize the sort of known deflection and pre-arrest diversion pathways, a great sort of point of reference. Core measures of pre-arrest diversion, so recommended for sites that covering police treatment, community, and race, the PTACC 11 guiding principles for behavioral health pre-arrest diversion, currently being aligned with CARF accreditation standards. The research brief, which is the first field-wide synopsis of deflection research. This is an important body of research that really sort of informs our approaches. And then the pre-arrest diversion presentation, basics, policies, and naloxone plus. So we have a number of resources that are free and available, and we would like to have you engage with us and understand how to engage and how to participate and add. Here are some upcoming events. Public Safety and Deflection on January 19th. Please take a look at the website. Please sign up and join us. We have Deflection Software on January 27th. Children and Families in Deflection. Deflection Research. So as you can see, policy and legislation for deflection and stigma reduction in deflection. So it really sort of unpacked many of the areas that are pertinent, and where we're going to sort of break it down into sort of bite-sized chunks so that we can really do a deep dive in helping everyone to understand how we're sort of approaching this topic. And here is finally a sort of reminder of Jack and his contact numbers. This is the best way to get in contact with PTACC. So with that said, I would like to bring it back to our panelists, and I would make a sort of comment that perhaps will inspire one of our panelists to jump in with some opening remarks, and that is that perhaps what we're seeing is it's the sort of largest deflection experiment in history in terms of what sort of COVID has sort of brought to the table. So I am wondering whether Dr. Bob would like to perhaps kick off the proceedings and comment on this sort of circumstances that we couldn't have foreseen at the beginning of the year.
Thank you, Andrew. My comment to start things off would be that it's really commendable that we have this, for lack of a better term, deflection movement in the United States. And certainly in other countries, we've had this going on for quite a while. So it's good that the United States is catching up to some extent. I think that's commendable, and it's a wonderful thing. At the same time, the big question becomes, for me, deflection to what? And that's the key, because at this point we are facing a crisis of credibility in addiction treatment. And what that means is not that addiction doesn't work, because it obviously does work for some. We just don't know how it works, why it works, and who it actually works for at any particular time. And so for me, the real issue that, if you will, the pink elephant in the living room that's been there festering for 50 years and now is starting to get rotten and smell pretty badly, is that if you have a loved one who needs treatment, and I will tell you, recently I had a loved one, and I've been in the field for 50 years, and I had one of my daughters came to me and said, Dad, I need to get some treatment. And you'd say, well, hey, 50 years in the field, working internationally, probably know 50 executive directors in the United States easily. I would have an easy choice. I had no idea where to send her. That's after 50 years in the field. The best I can do for her was get her an incredible case manager who can make sure that she got what she needed in real time, and that there was then that medication, assisted therapy, and harm reduction was available. Those are my thoughts, Andrew.
Thank you.
And just to piggyback off that, I think Bob brought up a good point. Prior to COVID, I know the county that I live in had established deflection and diversion programs. So when everything began to shut down in March as well as in May, there was already systems in place for deflection and diversion. So all we needed to do was pivot and make those connections happen in a world that was much different than a few weeks before. But when we're talking about deflecting to what, that's what we hear from the law enforcement that I teach, the law enforcement that I work with, is who am I sending these people to? Because they have so much on their plate working on the streets, doing investigations. And we've seen this movement of law enforcement officers who really do want to deflect and divert to something. However, in a lot of places, there isn't a clear-cut place to send them. So what we did in some of the systems and programs that we did was say, here is directly who you're going to make that warm handoff to. All we're asking you to do, besides doing a little bit of language training and some understanding about what addiction and recovery is, because that's so important and critical for the officers who don't understand, but is to pick up the call and connect them to a trusted provider that our programs have vetted, to a recovery coach or a recovery center, again, who we as the people who run the program have vetted. And what we've seen is when officers or the courts have the ability to have all of those tools laid before them, they are much more inclined, even in the midst of a pandemic, to pick up the phone and to make that warm handoff and make those deflection and diversion. And before I let somebody else chime in, what I'll say is what we saw is when everything shut down, March, April, May, those calls from law enforcement went up. So when we pivoted to a lot of virtual connection or telephonic connection, the officers still knew that they could call and connect these people with substance use issues to the people that we've built those relationships with. So, you know, I think Bob's point that we need to have these clear-cut ways for people to make the connections is at the forefront of anything that we're doing in any of our communities.
Thank you, Melissa. I'm wondering whether Rashad, you'd like to comment on what you're seeing, given your position and sort of being on that in the community, in the streets.
Yes. So our experience has been a little bit different. We have a single point of contact for 5 districts, police departments on the west side to connect to. And prior to COVID, we were doing a lot of outreach and engagement. We were doing roll call trainings with the various police departments. And we were only seeing a trickle of people, of police officers actually utilizing our services. We had to kind of do a deep dive into, you know, what's going on. Why is it that they're not utilizing this service where they can drop off? Their drop-off time is less than 15 minutes, so they're not spending, you know, an hour and a half to 2 hours in an emergency room, only to have that person evaluated and then subsequently released to the street without any linkage to care. And so, you know, I started talking with the district commanders. My community relations person was visiting the districts on a regular basis. And what we've learned is that, and this may be unique to Chicago, but police are not incentivized to utilize some of the alternatives that are available to them. In fact, they are more incentivized to use the emergency department because for some of them, that means that that's an hour and a half to 2 hours that they're off the street and they're not in harm's way. But we also learned that some police officers well, the way the system works in Chicago is if a police officer makes an arrest, and I'm sure this is true of other places as well. If a police officer makes an arrest, then there's a court date because, you know, the arrestee has to have due process. And that means that that police officer then has to appear in court. Well, court time is overtime pay. And so we have police officers who are, you know, using the system to their own benefit to get additional income. And so it's really hard to kind of, you know, penetrate that culture and bring about, you know, the shift in practices within the police department to have them utilize, you know, something like the West Side Community Triage and Wellness Center. The other thing that we learned is 2 of the 5 districts that we work with are basically training grounds for new officers coming out of the academy. And once they're trained, they're then reassigned to other districts. And so by the time we get one group trained and we get them motivated, and there are a lot of young, you know, officers who come out, they want to do good, you know, they're there because they really want to serve and protect. They take that, you know, that mantra to heart. And by the time we get them on board, they're gone. So prior to COVID, we were able to get into the police departments and do a lot of roll call trainings, a lot of marketing, etc. But then COVID hit, and you know, we were not able to do that. The other factor is that we discovered through some of our conversations with the districts that during COVID, they were basically doing what they called a catch and release. So if someone with serious mental illness or a substance use disorder was encountered, they say, you know, hey, you need to, you know, get off the street, you need to do X, Y, or Z, but they were not connecting them to treatment because of COVID. So it's had an impact on the utilization of the triage. We recently started seeing some uptick in the use of our services by some of the districts. And I think that's largely because of, you know, just the continued priming of the pump. And, you know, you have to be out there on a consistent basis, building relationships with these officers, you know, building relationships with the commanders, getting your local politicians involved. You know, we've utilized our aldermen, our Cook County commissioners, even our state representatives, you know, to really try to push this needle forward and get police officers to start diverting instead of arresting.
Thank you, Richard. What an important experience. I'm wondering whether perhaps Steve, with his experience in the treatment world as well, what's your experience? Any sort of thoughts or comments on how to increase the strength of those relationships in the community to facilitate this process of referral? You're muted, Steve.
Here we go.
Thank you.
So we are hearing how important relationships are, and you know, Dr. Bob and Melissa and Rashid have pointed that out in various dimensions. And one of the things that I've learned with working with justice-involved individuals, whether it be behind the walls or out in the community or in a diversion program, has been how important the very basic relationship factor is, and the ability to connect with other, I hate the word pro-social, but that's what we use a lot in the field, but just normal, everyday people who are struggling and managing whatever life situation they're in, but they're doing it in a way that's they're sober, they're not using, they're not causing harm to others, they're not breaking the law. And the ability to connect those relationships together. And what I found and learned over my multiple decades in the field is that the most powerful ingredient for change occurs in the peer-to-peer network that happens. And it happens in all our walks of life, doesn't it? I mean, we listen to each other as peers, as professionals, you know, the brotherhood of police, you know, each cop to cop is going to get through to each other on those crisis situations or those endearing situations better than someone from the outside. So what I've tried to do in all of my career, whether that's through therapeutic community modalities or through housing, which I was very much really core to my life and how important housing is to these individuals, to getting a safe and a safe environment that is drug-free, and an opportunity to create relationships again and get the confidence again that they are people of a dignity and worth, and it's not about what one has done, but about who one can become. And living with individuals like that for a period of my recovery process has been reinforced what we as professionals learned in the clinical world on how important relationships are. And one of the greatest joys that I have in my life is seeing guys comment to me, and these are guys who've done hard time, been in and out of the system, and then to tell the story of, Doc, the cops just came to the house and said, you know, we don't know what to do with this individual. Can you help us out? And the peer actually makes that connection into a placement, into a treatment resource. And the cops then come back and just say, you know, they meet at the sub shop and they just have a conversation and said, we didn't know where to turn, but we knew that you guys would know what to do because you know that world. And so there's that confidence of a relationship on the street level that allows for a warm handoff to occur, but it's not necessarily coming from professional to professional. The real meaningful handoffs come from peer to peer. And so I'm just excited when I see that. And I'll just share this quote that is from one of the guys who have ran the sober house that I'm very much involved with when good part of my career, and which was actually my home that I turned over to the guys coming out of the jails and treatment programs to run, and without professionals. And one of the greatest things that has been told to me over the course of working with these guys has been this. They said, Doc, you know, we used to run from those guys, speaking the cops. Now we run with them. And to me, that's what we try to do. And that's what recovery is. Really a process of relationships and connecting individuals on a peer-to-peer level for not only individual change, but then systemic change.
So,
Steve,
I'd like to comment on that, Andrew, for a second. So those are moving words, Steve, my old friend, Steve. And always good to be with you, and always have deep respect for your great work. And those are moving words. And I think the anecdotal information is really exciting, and it really is moving, and it really points us in a direction. But I need to say this, and I say this with the greatest of respect and love and respect to you. With the greatest respect, that without the clinical piece, let's stop calling it a disease. Let's stop calling it, let's take addiction out of the DSM-5. Let's look at it from a different, if you want to look at it from a different perspective. I'm not diminishing the value of peer-to-peer. I'm diminishing the reliance on it. And I believe the peer-to-peer needs to be supervised. And I believe the peer-to-peer needs to be clinically supervised by someone with deep experience. Otherwise, there's a chance they're going to move in a direction that is based on their bias and their lens and not necessarily the needs of the patient. And they can do that with a big heart and with a lot of compassion, but the outcomes will be disastrous. And I know there's a great movement right now for peer-to-peer, and there's a great movement for peer recovery. But unless they're using a wider lens that includes harm reduction, medication, and is open to multiple pathways to recovery, and is being supervised and couched in science, I think we're going down a road we went down 50 years ago. And that's why we ended up in this crisis of credibility, depending on people who had good hearts and good intentions, but led us to a dead end.
And I think that, I agree with Bob, but I also agree with Steve. So going back to peers, in our programs in New Jersey, we use peers throughout. However, something that we learned based on other deflection and diversion programs and models that we looked at was what Bob was speaking about, which was we need to have a clinical supervisor who's overseeing all of our coaches, not only for the well-being of the people that the peers are working with, but the well-being of our recovery coaches, because most of them are in recovery, and their well-being, especially in some of our programs where they're being dispatched in real time to overdoses, to arrest, to chaotic responses by law enforcement. We needed someone not only to check in about what was happening with the recovery that they're working with, but also to check in with the coach. And to circle back to a lot of what was said earlier about how we needed to make it, the best way to say it is easy for the officers. But when we were being told specifically in the beginning of COVID that they were essentially arresting people and then releasing them or not putting them in the jail, what we did was we made cards for them so they could hand off, here's your recovery coach's number, here's their name, call them today, call them tomorrow, call them in 6 weeks. Stop by the police department, use our phone. If you want help, services are available. And we found that to be very effective. And when we're talking about relationships, I think something and the approach that I've seen work in a lot of communities, not only is just to be authentic and to be passionate, but to bring everybody to the table, bring the community to the table, bringing the people who deal with harm reduction, who deal with housing, so that the issue can be addressed in a multifaceted way, not just be treatment, not just be peers. And something that we've done over the last year and a half, and I've had the opportunity to teach, is so even when we can't get law enforcement to make that phone call, we've been training other first responders. We've been training EMS. So EMS not only has their own training on how to get those people connected to services and make that warm handoff, but they can turn around to the officers and say, don't you have that deflection and diversion program? Can't you call that number? And again, recovery is contagious. When they meet peers and they develop relationships with them, when they see people recover, when they see the passion of the people within this field, it works. But sometimes it's a hard road to get there. So I appreciate Steve bringing up peers because we find that effective, and Bob to bring up the clinical part, because we all have to work together. And I think that's how we address some of these issues. But more critically, we do need to learn from the past so that we don't keep making the same mistakes over and over, and we're able to get more people connected to services.
Amen.
Right.
Amen. You know, I totally agree with, what I'm hearing right now. Just looking at it from the perspective of someone who works in a predominantly African-American community where mistrust of treatment professionals is very high. Certainly mistrust of police officers is at an all-time high. What we found is that our peers are the people who can break through that stigma and establish the relationships with people who are on the street who are using and get them into treatment. So that's a real critical part. I agree that supervision is important. And, not only from the perspective of making sure that, people are, doing best practices and things of that nature, but also I think Melissa mentioned, addressing the potential secondary trauma issues that peers may experience. But I would say that it's very important when looking at clinical supervisors that we really look at their level of cultural competency. There are a lot of LCSWs out there and licensed clinical psychologists out there who don't have a clue about how to work with people in these underserved, communities that have been affected by structural racism. They don't get the culture, they don't know the language, and so I think that that's a real critical part. There's one other thing I want to say, and this is really a shout out to PTACC. I attended the PTACC conference, Leslie, I think that was in 2018, when we had the first PTACC conference.
Right.
Yeah, and it was absolutely tremendous. We were in the process of setting up our community-based pre-arrest deflection project, and we're really pretty much, on the periphery of everything that was happening in the field. PTACC provided us with, the tools that we needed to really refine that process and to set up a program that's really become, a beacon on the west side of Chicago. But one of the main takeaways that I got from that PTACC conference was the importance of community engagement.
Yes.
And we came back and immediately started doing world cafes. We were having open forums with the community. We engaged the faith-based community. We engaged the law enforcement community. We engaged residents in the community. We had meetings with people who were recovering from substance use disorder and serious mental illness. And so the services that we offered were informed by that community engagement work. And so, anyone out there who's thinking about, getting involved in this work, really take this seriously. You've got to hear from the people who are being affected by the programs that you're offering in order to really tailor them at the level that they're going to be able to connect with those programs.
I'd like to jump.
Good, Leslie, please.
Okay, I'd like to jump in. Thank you. I agree with everything everyone said. I'm just going to kind of stir things up a little bit, if I may. I really believe, and I believe that we have to be careful not to reinstitute silos where it's recovery support against MAT, where I think that the best approach is to have multiple pathways into treatment and services, and that there's not one right and one wrong. There's the appropriate match that needs to happen, and I know that there needs to be resources in the community, but you have to I'm gonna kind of ramble for a bit, so bear with me. we're in a COVID pandemic, right? And it's affected access into treatment. Arrest data is not always reflective of what's really going on in the community because they're trying not to arrest, which is good, but we don't have the data. But we're in the middle.
Leslie, I'm afraid we've lost your feed. Your volume is not working. Give you a second to put on some headphones. Hopefully that fixes the problem. And I wanted to share, we do, perhaps if you're able to come back on, Leslie, we also have a question from the audience. And the question is there a good assessment tool for a law enforcement to be able to assess whether somebody's appropriate for diversion? So I'll leave that to the end of your...
I answered that in text, but as Leslie resolves her issue, I can jump in. I borrowed and spoke with multiple other diversion and deflection locations on what their directives were, but also looked at some of when I attended the PTACC conference in 2019, was able to hear what other people were doing and update our plans. I think it really depends on what your community wants. But I think, again, not leaving it up to the officers to make those judgment calls on if somebody is eligible is critical. What we saw is our numbers went down when we started like that. And when we then just promoted a warm handoff to professionals, treatment providers, to peer recovery specialists, what that did was it then gave people who have experience the ability to assess people. And so what I said in my answer was that, I don't know if you're getting, okay, was that we really just keep it very broad and we just exclude, for the most part, violent offenders in our particular area. But again, I think my community is very different than the west side of Chicago. So you have to look at the community that you're serving and tailor your assessment tools to that, but again, defer to the people who have experience. Unfortunately, most of the officers don't know what they don't know. And as the people doing deflection and diversion work, we have to teach them what we know.
Thank you, Melissa. Leslie, you're muted.
I'd like to add to that. I think that was really well said, and I agree with what Melissa said in terms of being you need to reflect the community. As a matter of fact, not only tailor it to the community, you need to empower the community. And if the community stakeholders are not part of the system, then you don't have people to support sustained recovery. But I want to just piggyback on the comment on cultural humility, because it's not just cultural understanding, and I think people get very confused about the difference. Cultural humility is the difference between cultural humility and cultural sensitivity is the idea that you need to understand that you cannot walk in those shoes, but you need to be sensitive to those shoes. You can't assume that you understand what's going on, but you can understand what people are feeling, but you can respect what people are feeling, and you can empower those in the community to make those changes without trying to make those changes yourself. And if we were going to cut right to the chase, the crisis that we're talking about right now is not new. It's 50 years old. The only difference is that mostly for the last, for the first 40 years, it's been about putting Black people in jail. And that's the reality. Unless we have that historical context and unless we understand that piece, I think we're missing a big part of what we need to do moving forward. We're not starting from today. We're starting from back then. And we need to understand that if we're going to have change, some of that change has to be in the community and systemic.
Right. Can everyone hear me? I apologize for the interruption. So I've tried to pick off, and I was just making the point that not only are we going through COVID pandemic, but an opiate pandemic in my mind, and also particularly in Chicago and some of the other urban areas, the whole issue of gun violence in these same communities. And then at the same time, they're releasing people from prison for early release for COVID and some other reforms that are being done at the high end. And they're all going back. These are all, in my mind, I don't have the data, Dr. Bob, exactly, but I can get it. They're all going back to the same zip codes and the same families and the same troubled communities that need resources in terms of programs and jobs and housing. And so we not just have COVID, which is horrific and has brought on the challenges of themselves, but it's being layered onto communities that have already been challenged to overcome some of the issues that have been going on for years. And on top of that, you've got funding crises where some of the smaller community programs don't have the capacity to write for federal grants and do a lot of fundraising, and they have to abide by, at least from a behavioral health treatment perspective, you have to abide by Medicaid and what's allowable and what's not allowable. So I guess my point is you have multiple crises. And I know, speaking for Chicago, because I am from Chicago, there's a real, the importance is you're in a community, but the initiatives between and the partnerships between behavioral health and law enforcement based on relationships, we need to begin to build our own communities and build those communities and approach all of this as building a community or rebuilding community, not just the actual, mortars, brick and mortar, but the actual feeling of community where there's people that are working together and not siloed. And so I'm making multiple points, but I just want us to proceed, those of us that are in a position to make recommendations or just talk to people, as that one way is not better than the other, that we need to incorporate all of the different pathways in our tool chest and work together and build those relationships, because we have a lot of challenges, you guys out there, not just COVID, and even one, we just have those challenges, and we need to not see the other as an enemy, and work in collaboration to implement deflection programs or reduce the barriers at the front door, or whatever the particular issues are in your community. So that's kind of me playing catch up here for a minute.
Thank you, Leslie.
Well said, Leslie.
Thank you.
I wanted to sort of just ask the panelists, because we're also sort of addressing some sort of systemic issues. And, Bob was talking about sort of also a 50-year experience, and hopefully we can surmise some lessons from those 50 years. The case for case management as far as care coordination, which is yet to sort of join the sort of treatment piece as far as being a reimbursable service. But it does seem that whether we try to sort of fill the stopgaps with sort of peer services or volunteer services, that it's just a missing piece. And I'm wondering who would like to sort of address this and share their experience with this.
I can address that. We use our peer or community outreach and engagement workers to go out and actually, make the connections, bring people into treatment. Once that individual comes into our triage center, there are a host of staff who have expertise in various areas, from an advanced nurse practitioner who checks them out for, any health-related issues, a crisis triage specialist who does the initial assessment and makes a determination as to what level of care this individual may require. And then we have a case manager who actually does the warm handoff to a treatment provider, and who also conducts follow-up, 7-day, 14, 30-day follow-up to make sure that that individual has been securely connected to treatment and that they're continuing to be engaged in treatment. And if we find that during that period they're not engaged in treatment, then our outreach and engagement staff, who are mostly people with lived experience, go back out and they start the whole process over again of trying to re-engage the individual and bring them back into treatment. But that warm handoff by the case manager is really critical to making sure that we have secured the proper level of care and then that individuals are really engaged in the process.
I think that I agree with you, Rashad, but there's no buts. I agree with you. I know that I was at a focus group with the West Side Opiate Task Force, and there was a wonderful focus group with some of the clients from the West Side who have tried to access treatment, or they were in recovery, and they were just talking down and dirty about what some of the barriers were from their perspective in terms of accessing care, or accessing care from detox into housing, into, and they expressed very eloquently the barriers that they were feeling on the street level, on the community level, that they would go through a detox program that approved Suboxone, or they were on methadone and they were stabilized on methadone, and then the recovery home that the case manager or care manager referred them to, and that particular recovery home doesn't accept methadone, or only does Suboxone, and so the criterion, I don't think we could solve this overnight, but some of our own, from a behavioral health perspective, we create the barriers. I mean, we don't, it's just mind-boggling if we could take ourselves a minute into the shoes of those trying to access treatment without this hotshot care manager that's trying to navigate. It's mind-boggling. It's mind-boggling from them. It's frustrating. And I think that there's a beginning of some really good communication and working together collaboratively, but we have a long way to go. We have a long way to go, not just in Chicago, but all over. I mean, Melissa talks about her county, and it's great. It's a smaller county, but I just think we should never be afraid to, without taking it, and I don't mean it towards you, Rashad, at all. I'm just saying in general, take it personal when the systems that some of us spent years building aren't working, and they're not working for particular reasons. And I think that we need to call it what it is. We need to call it what it is and have those relationships with our colleagues and peers where we can work some of that stuff out. I know we work some of that out so that we never lose sight of what it's like to walk in the shoes of a person that's struggling with substance use disorder. That's not just about the drugs. It's the whole culture of addiction, the criminality, the family challenges, good and bad, the resources and strengths in that family, the children that are at stake. We need to, as leaders, never forget what it's like to walk in those shoes. And even if we have peer support folks out there and people with lived experience, my opinion, they need to be integrated into a team so that it's multidisciplinary and that they're learning and growing from each other. And whether that's a direct clinical supervision or just being part of the evolution of our industry. And so it's just, we have a lot ahead of us. And the first step towards that are conversations like this, where we're bringing people together to talk about what the real challenges are. And not that we're not doing it, we're doing that. But I just keep putting my mind, because that's how I was trained as a young counselor, to get in there, to get into the community, and never forget how the importance of those communities, and incorporate it into my clinical, into my decision-making ability. But so I just think, I encourage everyone, if there's an issue, we have to be able to say what the issue is. If it's data collection, if there's no research, then we need to define what those issues are and tackle it together.
Let me piggyback on that, and because I think those are words of wisdom, but let me just piggyback. And what I would say is that when you use the term treatment, make sure that we're using a wider lens than we've used classically.
Yes.
This whole idea of access is the same as the handoff, is the same as deflection. Access to what? And it doesn't make sense to advocate for access unless you're accessing to something that meets the patient's needs as they understand them, not as you understand them. But the important thing about understanding treatment is understanding that housing, transportation, childcare, employment are the things that sustain recovery, not CBT, not DBT, not EMDR. I've never heard someone over more than 50 years say I have long-term recovery based on my CBT. And it just is not the case. But I have heard people say, look, I'm doing well because I have a job, because I have a place to live, because I have transportation, all the things that build respect, all the things that, and how do we do that? And you mentioned community, Leslie. When I think of community, I think about community stakeholders. I think about not empowering treatment programs, but empowering people in the community who are stakeholders, who are the people who can sustain recovery. Who are they? They're the people that provide jobs. They're the people that have housing. They're the people that provide medical care. They're the people that provide education for children. Those are the stakeholders that are so much more important than treatment centers and outpatient and inpatient this or that, which we've had for 50 years, and quite frankly, with great respect, has not made a difference.
Yeah, and just to piggyback off of that, something that I preach all the time is having recovery-ready communities, developing these ecosystems, making sure that there is employment opportunities, that there is education, something that worked in my own personal recovery. And again, I'm under no delusion that I had access to some of these services because I am a white female who grew up in a rural area. I had family support. I had what we talk about today as a substantial amount of recovery capital, even though I was still in the middle of my substance use. That is not where a lot of people stand when they first come in the gate, and we need to recognize that. And I never forget that when I'm dealing with issues that pop up into our community. And just one short thing about like these abstract ideas, taking it to the streets. How do we address some of these issues? Something that came up in my community was that we have an issue getting people in the doors of treatment, which is usually the first stop for somebody if they're on opioids or they need some sort of acute care. Individuals did not have IDs, so they were being turned away and put back into the community. So what we did was the prosecutor's office, the sheriff's office, the treatment centers got together. We put our heads together, and now the mobile unit that goes out in our community to address substance use within our county can print IDs. And so again, this is something you need to fit your community issues into the systems that you have. And that's why, and I agree with Leslie, bring people in recovery to the table. Let them tell you, but when they're telling you what their issue is and they're upset about it, don't just turn around and say, oh, it's not us. Who do you know that can address this issue? And then make it happen, because we talk, but frequently we don't do. And that is the obstacles we see and the frustration from the community. But if you are unfamiliar with recovery ecosystems or recovery ready communities, I would urge the people watching this to take a look at what that really means, and then to evaluate your community and then go out and change some of those things. Because even without having a conversation with the people who are utilizing those services or who might need them, I'm sure that you can identify something that you can do within your organization, your law enforcement agency, that can improve your community and make it recovery ready.
Well said, Melissa. And I just to piggyback onto that very quickly, is that, and I think this is a key term. We throw out these words like recovery, and we need to understand that when we say because I think there's a knee-jerk reaction by many folks that recovery means abstinence, and that's how we measure recovery. And we got to understand that recovery is an individual process, and it doesn't necessarily mean abstinence. It may not mean abstinence at all, and then at the same, on the other hand, it's necessarily abstinence for others, you know. So we know that, but unless we have someone who could not only get someone into the right church, we need to get them into the right pew. It's right. It's, you know, so it's one thing to have the behavioral health addiction umbrella, and that's really important. So we need to get people under that umbrella, but you need programs like Rashad's, those that community-based centers that can provide that kind of triage and assessment and get people what they need, as opposed to, you know, providing access or funneling them into a treatment center that makes no sense for them.
Yeah. Thank you, Dr. Bob. In fact, I wanted to piggyback on the experience of a recovery-ready community. I worked in northern New Mexico a few years ago, and we had a task force because what we were discovering was that, you know, a lot of individuals who had been through different systems were finding it difficult to maintain or sustain employment because of some of the legal requirements or parenting requirements that sort of made it part of the system. So as a task force, we engaged with the Chamber of Commerce, and we engaged with several businesses, and we had created a sticker. So it was sort of recovery-friendly towels in northern New Mexico. And the idea was that the employers were committing to helping people in early recovery and provide a level of flexibility that would help the individual sustain their employment and also all the requirements of being in the system. So just to throw in that as an example, Melissa sort of inspired me to kind of share that.
It really does take a community, doesn't it?
Yeah. It does.
Yeah.
Well, I've done a lot, even though I'm born and raised in Chicago and kind of was raised in the field in Chicago. I've done a lot of national work, and I've done a lot of work in Appalachia, and where there was minimal resources and treatment programs in those communities. And it's exactly what Melissa said, is the church, the faith community, all of these social service agencies or the, you know, Department of Public Health or whatever resources were going into that were in that community, pulling them together and finding a champion, you know, a champion that has a little bit of juice out there, where you touch them and touch their heart, whether that's, in many cases, they've experienced overdose in their families, or a loved one or a neighbor with addiction, with substance use problems, and they I'm sorry, and they championed, whether it was, and many times it was the police chief, or it was, you know, the mayor, or whatever it is in that community that can that can be part of these stakeholder teams. And those leaders emerge, or either they're there or they emerge, or there's backup, funny how that works. And that's what pushes those through. And they've come up with the most creative ways, whether it's community service in lieu of jobs and getting federal, getting dollars to be able to pay community service workers to do work in the small towns. There's so many avenues. And when you have everyone together, family, working with families, there's models out there where they've successfully, integrated the whole issue with child welfare and their families and issues with special populations. But anyway, I just am piggybacking that those resources, whether there's a lot of like Illinois, if you were to look, they do invest a lot of money into treatment, not enough treatment and other services. The only thing we're seeing that gives me hope is that there's partnerships and there's more dialogue between the entities on a state, county, and city level. There's more dialogue where there's an encouragement to work together. But that takes work.
I'm sorry.
Go ahead.
It's interesting. I agree with everything you're saying, Leslie. I worked in three areas. That one was in Camden, New Jersey, where I spent a great deal of time. Talk about minimal resources. I brought people there from third world nations who couldn't believe that we had such a. We have a dog in the background.
I know they can hear the dog. Sorry, apologize.
Where they could not believe what was happening in Camden, New Jersey. I worked in the with the Navajo Nation, if you want to talk about very few resources. But recently, if you look at the article we wrote on Turkey, and in Istanbul, Turkey, we had very little resources. And we began with a very traditional treatment program, what you would call an outpatient treatment program. And it failed miserably. I mean, it was terrible. And not because we're so smart, because we're not that smart. I was not that smart at the time. I probably still am not. But through a Hail Mary pass and said, let's bring in only community people. And let's empower people in the community. And that included everything from the resource and garbage department to the police, to just about every stakeholder that you can imagine. And the program got on fire. It was amazing. People were getting engaged in long-term and sustained wellness. And it's just unbelievable. But when you look at community, you got to get out of that knee-jerk reaction to think about treatment. Because if we keep thinking and it's so hard, because many of us have been doing this for, like yourself, Leslie. You go back to the 80s, I go back to the 60s. We've been doing this. As Rick knows, I like to say I've got genes older than you. But the thing is that we have this knee-jerk reaction to think about treatment. And we need to think more globally. We need to think more systemically. We need to think about dealing with people in their environment and respecting not what we want, but what they want and they need in real time, and what makes them well, not what our thought about wellness is.
Agreed. I think, Bob, and just to throw in some additional information, but so when I'm talking, teaching, working with law enforcement, a conversation that we have all the time is about harm reduction and what that means, but also giving them the ability to know what a handoff to a harm reduction center looks like. And of course, we get some pushback, again, because people are so focused on that abstinent-based pathway or that 12-step pathway. But when we break it down for law enforcement and teach them why it's important and what wellness essentially wellness looks different to everyone, you really see hearts and minds begin to change within the law enforcement community and the community at large. So just simply stating to them, when they go to one of the 7 harm reduction centers in New Jersey, it's not like they're just handing out needles in their sterile syringe exchange programs. What they're doing is providing other services. So if it's HIV testing or connection and warm hands-off to other services, as well as giving a person, if they want to use with some degree of safety, explaining to them how that's transformed, at least in the recent years here, to also include fentanyl test strips, which is something that, again, is being used to save lives. And what I explained to them is, okay, although you don't believe that somebody should be using drugs, people will continue to use drugs. So if we can give them the ability to use safely, keep them alive, and potentially, maybe not, but maybe they will have a chance at some other type of recovery in the future, if that's through medically assisted treatment, if that's through abstinence-based, through a faith-based program. But again, I think having these conversations with law enforcement, with the communities, and not keeping people so boxed in to what this standard, what is recovery, just abstinence basis, is so important. And to circle back to something that we were talking about earlier, with clinical supervision and the use of peers, because a lot of the peers, at least that I've come into contact with, do have that 12-step background, constantly reminding them that their focus is multiple pathways. So if the person wants to continue using, if the person wants to get on methadone, Suboxone, Subutex, Vivitrol, we should be giving them the opportunity to do that, because we're not here to dictate how a person chooses to recover. We are just merely the person who's helping them navigate some of these complicated systems and communities that we live in.
So important, Melissa. Thank you. A non-binary approach to the recovery process. Steve, were you wanting to jump in? Thank you.
I was, again, I was on mute and I was just saying exactly, it's a I think what I'm hearing from everyone, it's really, it's a non-binary approach and that we need. And I think we have evolved over time as a field and an industry, and we need to keep on evolving. But I'm just encouraged to hear this dialogue among all of you with so much experience from different points of view, and it is very encouraging, because really what we want to do is, number one, and this is for my correctional environment, we want people not to reoffend and not to hurt themselves or others, and we want people to be well. And how do you get there? And there are multiple pathways of getting there. And it may be, like Melissa was saying, it may be partially with the MAT, but MAT is not an endpoint. Treatment is not an endpoint. There's no single endpoints. It's multiple, and it's a journey of growth and processing. And we all need each other to be able to keep moving forward. And I know for offenders, they need peers who are good role models for them. The peers who are good role models need good, as Bob was saying, good supervisors, and Melissa was saying, to help them keep growing on their journey. I need it from all you folks, keep me growing on my journey. So, and I think that's important to keep in mind, that this is a process. It's not an endpoint. And we're all in this journey. And so our officers who are on the front line and dealing with the stress of being on the front line, they need to know that they're not alone in that, and that they can reach out to us clinical folks, and us clinical folks can reach back to authority figures who can really get people's attention better than we often can. So it's exciting to me, because I think, and COVID getting back to Andrew, to where you started this, how has COVID really impacted the change process? What has been inspiring to me is I have seen treatment centers respond more, be creative. I've seen, folks, offenders who would never know how to use Zoom, be taught how to use Zoom and attend Zoom sessions. And so their obligations to the courts are continuing. And then to hear from the clinicians provide a point of view and say, oh my gosh, now I really understand what that person was talking about, how difficult it is at home, because they saw the Zoom in their own home, and the kids and the spouse and all the banging on the doors next door. And so it created a real lively environment of what that person is going through, and how hard it is for them day to day to live in this tough, very harsh society that we have become in so many sectors, in a way that keeps them moving in a way that's not reoffending and not hurting themselves or others, and getting well.
What an important point.
I think that what we're really saying here, and I think that was eloquently said, Steve. I think what we're saying here is that we need more programs like Rashad's and Melissa's.
Yeah.
I mean, I think those are two really outstanding models, for moving forward, because, and so rather than advocating for putting more money into things that we have no idea whether they make any difference, putting more money into the kinds of warm handoffs that Melissa is talking about with the kind of work she's doing. And I would replicate Rashad's Center in every single community in the United States if I was in charge. And that's where I would put my money. And I would take it, and I would take it all away. Look, I mean this respectfully, but I'd be closing inpatient treatment centers, like I was pulling weeds in my garden. I would that's because we have no idea all we know about them is that they cost a lot of money, and we have no idea whether they really make a difference. But we do know that programs like what Rashad is doing, and I can show you the data, and programs like Melissa is doing, and I can show you the data on that, because I'm not only a clinician, I'm also a scientist. I can tell you that's where real change will take place. And that's how we'll make a difference. And that's when the tail will stop wagging the dog. If this needs to be the head, not the back end of treatment. And we need to shorten the acute care interventions, which have historically been the whole enchilada has been acute care. And then we expect people to get well without, continuing care and sustained recovery. Shorten that acute care model, get people some traction, and get them into programs like Rashad's and Melissa's.
Well said, Bob. It's a chronic condition, and treating a chronic condition with acute care measures, it's missing the mark.
Yes, I also wanted to thank you, Bob, for that as well. One of the things that I've been trying to do relative to my own education and to become just more attuned to what's happening in the recovery community is I've been spending a lot of time talking with various people who are involved in recovery. And these are mostly people who are either currently using or who are former users who are in, what they have defined for themselves as recovery. And I never question what that is. But I had an opportunity to talk with a couple of people a few weeks ago. And to my surprise, I learned that they have established, and these are people who, again, one of them has about 14 years of recovery, another has about 19 years of recovery, and they have established their own recovery home for people who cannot get into the established treatment facilities, and they're providing recovery services free to these individuals. Someone who went to a recovery home and was told that they couldn't stay there because they were taking Suboxone, or they couldn't stay there because, you know, they relapsed. They're taking these people in and providing them with, you know, the love and the support that they need to be able to, you know, to sustain themselves at whatever level they're at. Some of them are working toward abstinence. Some of them are working toward, you know, just reducing, you know, their reliance on the drug. But I think that, you know, we need to find a way to identify these efforts and to also to help sustain them in the community. So one of the things I'm looking at for my center is how do we incorporate these kind of natural systems that exist within the community. They're not going to be able to bill Medicaid. They're never going to become part of the MCO. But how do we identify resources to sustain that effort so that that's truly empowering the community and helping people, you know, get to the point where they can, you know, just lead a meaningful life. And that has nothing to do with, as Bob was saying earlier, they're not doing CBT, they're not doing DBT, they're not doing any of those evidence-based practices, but they're saving lives and they're helping people move their lives into a more meaningful place.
Providing.
Oh, well said.
Rashad, let's talk about that.
Sorry, Bob, just 1 second. I wanted to remind everybody that we have about 5 minutes left and all attendees can ask live questions. Thank you, Bob.
Yeah, I just wanted, I'll say it quickly. I just wanted to say to Rashad, let's talk offline or whatever, but I think that you've just hit the nail on the head, and we can talk about how you actually do what you are suggesting. How do we create these systems with finite resources? But I would love to have that discussion with you, Rashad, when we have the time.
Thank you, Bob. We'll be in touch about it.
You know,
If we can do it as a webinar and have a broader discussion.
Yeah.
Right.
pending any questions from
And
the audience.
even bring some of these people to the table so that we can, you know, really have some meaningful dialogue and learn more in depth what they're doing. You know, we need to learn from the community.
You know, Rashad, I just want to say that I admire you so much as the leader and with everything on your plate, that you approach this with the attitude that I'm still learning and I need to learn and discuss. I don't know it all. And just like for you to role model that in leadership, having, you know, you're I mean, not just the triage center, but you're the CEO of a major mental health clinic or behavioral health clinic on the West Side, and that you continue to want to learn from the people that it's actually affecting. And I just admire you a lot for that. We need more of that on every level, even from a government perspective, to make policy. And it might be wonderful things, but how does it play out in the community? And have you heard the voices from the community and the stories? So I just admire you so much for that, Rashad.
So
I
agree.
I agree. At the end of the day, we're just all struggling pilgrims. And if we
Right.
if we think we're anything more than that, then we ought to go home.
Right.
Great.
I would like to sort of ask both Rashad and Melissa perhaps to close because you both mentioned your participation in PTACC. So even when you are right in the middle of it and you have a successful model, how important has it been for you to be part of PTACC, to be able to engage in these conversations and sort of be inspired or galvanized by other people's experiences?
I think it's been tremendously helpful. Rashad had presented at the last conference and talked about his center in Chicago. And so my team and I came back to our community and really worked with our our government to get a recovery center, nothing like what he has in Chicago, but at least a start up and running, and learned from him and what they're doing to bring that here. And we've, they've been able to launch it even virtually through COVID. And so again, being able to learn from other people, to bring other people's amazing ideas to our community, but also to share experience with others has been tremendously helpful and impactful. But also sometimes it feels very lonely working deflection and diversion, specifically in law enforcement, because although we've talked about all the really great things about deflection and diversion, there are some days where I am facing a lot of resistance from all sides: treatment, law enforcement, community groups. And so to be able to come and have very candid conversations and to just keep moving forward, PTACC has given me the opportunity to have a support system, and I am very grateful for that.
Thank you.
Yes, I would echo everything that Melissa shared. When I started the Westside Community Triage and Wellness Center, quite frankly, I was motivated because I just really got tired of hearing about how Cook County Jail was the largest provider of mental health services, not only in Cook County, but in the nation. And just recognizing how traumatizing it must be for individuals with serious mental illness and substance use disorder to be thrown in jail like that. It really kept me up at night. And I felt like I had to do something about it. So I reached out to Cook County Health and Hospital Systems, and fortunately was able to secure some funding from them. But I didn't know anything about deflection and diversion. I never heard about deflection and diversion. I was only doing what I thought was intuitively made sense. From a community organizing perspective, it made sense. But so PTACC really provided me not only the validation for some of my own ideas, but then the technical tools to refine them and to bring this this vision, into a real, functional day-to-day operational center that I think, we would not have achieved the level of success that we've achieved today were it not for the knowledge that I've gained from PTACC. And since, attending that first conference, I've become a member of the National Leadership Council, and now I serve on the executive board for PTACC. So, now I've got access to all of the inside information, and it's just really tremendous, to have all of these experts, Leslie, Steve, Bob, Jack Charlier, I cannot say enough about. He is the man. And, from the first moment I met him, there was this connection and a sense of commitment and synergy from Jack that I think really drives PTACC. So for those of you who are, on the call, I know Jack's contact information was put up. I would really encourage you to reach out to him. He has a wealth of knowledge. He is the expert on deflection. And so if you want to know more, if you want to really get engaged in this process, please reach out to him.
Thank you so much, Rashad. And we are coming to the end of this webinar. Thank you. I mean, I could go on for another hour to talk about this. There's so much to talk about. We look forward to seeing you all on the next series. Please share this with your friends and your colleagues and your peers. As has been said, there's a wealth of information here. Regardless of where you are in the process, you will find very, very useful tools. And of course, the more people are engaged in this conversation, the more meaningful the difference that we can all make. And I shall leave you just with, here are some upcoming PTACC events. And thank you very much all for joining us, and look forward to seeing you soon again. Bye-bye.